Okay. Well, it's a pleasure to sort of be here. Um, it's very odd uh, not being able to see all the people out there. I'm sure you all look lovely, and you're smiling and happy to be here. My charge today is sort of enormous for 25 minutes to go over follicular, other indolent lymphomas, and Hodgkin lymphoma, but I will do my best. This slide shows the relative incidence of lymphoma subtypes, non-Hodgkin lymphoma subtypes, the most common being diffuse large B cell, which accounts for about a third of the now almost 80,000 new cases a year. Follicular lymphoma is around a quarter, and all the other histologies are much less common and in the single digits. The indolent ones are the small lymphocytic lymphoma, the marginal zone, and the lymphoplasmacytic or Waldenstrom's macroglobulinemia. Hodgkin's lymphoma is only about 10 or 15% of the total lymphomas. When a patient with an indolent lymphoma walks into the office, the first discussion is, other than you've got the diagnosis, is should you be treated or not? And the patient goes, oh my God, you're telling me I have cancer and may not be treated. And yes, there is the watch and wait, or the patients call it watch and worry method of management. And this is based on several studies conducted quite a long time ago. This one was by the British group, in which patients were randomized to observation alone if they had advanced stage asymptomatic untreated follicular lymphoma, or chlorambucil, which was still being used in Europe in those days. And the cumulative survival and the disease specific survival were identical. And importantly, after 20 years, 20% of patients still didn't need treatment. And every treatment is associated with toxicity, expense, nuisance. And if you can wait, well, new therapies are coming along. So for patients who we are deciding whether they really need treatment, we tend to use what's called the Guelph criteria. And this is shown on this slide. You can defer treatment if patients have no masses up to 7 centimeters, greater than 7 centimeters. If they have fewer than 3 sites that are larger than 3 centimeters, if they don't have systemic symptoms, fevers, chills, drenching, night sweats, weight loss, etc. If they don't have substantial spleen involvement, don't have collections of fluid, aren't at risk of compressing a major organ or vessel by a lymph node mass, if they don't have a large number of lymphoma cells circulating in the peripheral blood, or low blood counts related to bone marrow involvement. So if they fulfill these criteria, you can wait, and some patients can wait for decades. So when a patient comes to us, we also assign a risk group. Now, there are several risk scores out there. There's the FLIPI score, which is based on nodes, LDH, age, stage, and hemoglobin. The FLIPI-2, which is in the post-rituximab era, beta-2 microglobulin, hemoglobin, node size, age, and bone marrow, and more recently incorporating the over or under expression of 7 genes, the M7 FLIPI. So a mutation of 7 genes, performance status, and the FLIPI-2. And we give them this score, and it gives us an idea of how they're likely to do, but it doesn't tell us what to do with the information. We do not change our treatment based on these findings. How do we treat these patients? Well, after a number of randomized trials out there looking at various regimens, the most widely applied is bendamustine and rituximab. Bendamustine is a drug that's been around for almost 60 years, developed in East Germany, and they had promising results. And then Professor Rummel from Germany did a randomized trial of bendamustine rituximab versus R-CHOP in untreated indolent lymphoma. And the BR had a longer progression-free survival, 70 months versus 31 months, with less toxicity. So it became the standard, but the curves kept going down and down. So a number of attempts were made to improve on the outcome. One of these is the concept of maintenance therapy, continuing the rituximab for, there are lots of ways of doing it, 6 months, 12 months, 24 months, indefinitely after the completion of the initial chemotherapy. They show the same thing. In panel A, there is a longer progression-free survival. In panel B, there is a longer time to next lymphoma therapy. Panel C, time to next chemotherapy, but they all share the fact that there's no improvement in survival. And yet there's more expense and there's more toxicity. So in my practice, I did not recommend, in fact, I tried to talk patients out of maintenance rituximab. And this shows some of the safety data. And this trial was out for 10 years. And it showed that there were more adverse events, 57 versus 38%, more grade 3, 4 adverse events, more serious adverse events. So if it doesn't prolong survival, you've got increased costs, more adverse events, it is not terribly appealing to me. Another way to try and improve things is use a different antibody. And there have been, a dozen attempts to create a better version of rituximab. The one that has stuck is obinutuzumab, which is a second generation anti-CD20. And it was studied upfront in follicular lymphoma in what's called the Gallium trial. And patients received either rituximab and chemotherapy, which could have been CHOP, CVP, or bendamustine, or rituximab. So obinutuzumab versus rituximab with the same chemotherapy. And what they found was there was a longer time to progression over there, but the survival was the same, and there was greater toxicity with the obinutuzumab. So even though the regimen was approved by the FDA, it is not widely used. In about 2004, our group came up with a regimen we called R squared for rituximab and Revlimid or lenalidomide. And I'll show you how active it is in the relapse setting, but it was also looked at as a frontline regimen. And unfortunately, the company did something they shouldn't do, is they did not listen to their advisors who said, make this a study that shows that that rituximab and lenalidomide is comparable to chemotherapy. But no, they wanted to show that it was more effective than chemotherapy. So they did the relevance trial, which showed that the response rates to R squared and R chemo were the same. The complete response rate was the same. The progression-free survival on the left was the same, and the survival was the same, only there was less toxicity with the R squared regimen, except for rash. So you have something that's just as active, better tolerated, and it isn't approved because they insisted on showing it was better. I believe it's a compendium listed, but in the front line, it is not approved by the FDA. One thing we've learned that has kind of guided clinical research and practice for the last 5 years is what's called POD 24. If you look at patients with follicular lymphoma treated with R-CHOP, it's not clear this holds up with other therapies. If they do not have an event, meaning progression of disease at 2 years, 24 months, POD 24, progression of disease, if they don't have it, their survival is the same as an age-matched population without lymphoma. And some of those patients, in contrast to what we used to say, some of those follicular lymphoma patients are cured. The other group that has a progression event within 2 years, instead of having a 90% long-term survival, has about a 40%. So POD 24 is considered an important landmark. My patients used to come in at the 2-year mark. I'd say, look, If you're 2 years, you haven't progressed, your survival is likely to be normal. Fortunately, we are moving away from chemotherapy in the management of follicular lymphoma, and we have a slew of targeted agents which are being studied, and some of them are approved. The ones with asterixes are FDA approved for follicular lymphoma. We have in the gray monoclonal antibodies, such as I told you about obinutuzumab. There's an ublituximab, another anti-CD20. There's magrolimab, which is a CD47. But there's also one that was just approved for diffuse large B cell, and that's tafasitamab, which is an anti-CD19. In the kind of purplish are those drugs that target the pathways inside of the cell. There are the Bruton tyrosine kinase drugs, such as ibrutinib and acalabrutinib, and more recently, zanubrutinib. There are the PI3 kinase inhibitors. I call them the ISIB sisters, Idela, Copan, Duvil, and umbralisib. And then there's the drugs that target BCL2, which is a protein which prevents the lymphoma cells from dying, and EZH2, and I'll show you some data of an EZH2 inhibitor just approved. And in yellow are the drugs that target the micro and I already showed you lenalidomide. There are the checkpoint inhibitors, nivolumab, pembrolizumab, and atezolizumab. And finally, there's CAR T cell therapy. But approved therapies in the relapse setting are few but growing. One of them was based on the Catalan trial that we did, in which we looked at patients who were refractory to rituximab, and we gave them either bendamustine alone or bendamustine and obinutuzumab, which is the G, it used to be GA101, and also had maintenance with the obinutuzumab. And we showed that not only was the progression-free survival whoppingly longer when you had the obinutuzumab with the bendamustine, but even the overall survival was longer, which at the time was unheard of in the relapse setting in a clinical trial. So this became a standard therapy in second line. Another second line regimen was approved based on the Augment study, in which R squared was compared with R placebo. These patients had relapse or refractory follicular or marginal zone. They could have had one or more prior chemotherapy or immunotherapy regimens. This was a large study and lots of follow-up. And what it showed was that R squared was superior to R placebo in progression-free survival in the upper curves, huge difference, and even in overall survival in the lower curves. So this was recently approved by the FDA as a second line therapy for follicular and marginal zone lymphomas. Then there are the ISIB sisters, the PI3 kinases. The three that are approved are copanlisib, idelalisib, and duvelisib. We expect umbralisib to be approved by the end of the year. They're all oral except for copanlisib. And if you look at the overall response rates, they're all around 50, 60%, except for duvelisib, which seems to be a little lower. The progression-free survival ranging from a year to year and a half, except duvelisib seems to be a bit shorter. But these aren't comparative studies, so you really can't say definitively that one's better than the other. But the complete remission rates range from 10 to 20%, except for duvelisib, which is 1. But what's more important is the toxicity. And idelalisib and duvelisib have associated toxicities in excess of the others. Increase in liver enzymes, diarrhea, colitis, inflammation in the lungs, infections, etc. Copanlisib has also hyperglycemia and hypertension. The best tolerated of the bunch appears to be umbralisib, but we'll see whether that holds true when the drug gets approved. The newest drug on the block is tazemetostat, the EZH2 inhibitor. It targets a gene, a mutated gene called EZH2. I'd give you the whole name of it, but it is not easy to say. Hopefully somebody laughed at that out there. Okay, the drug is an oral drug, and in the mutated population, the response rate is 69% with 12% complete remissions and a median duration of response of 11 months. Looks exactly the same as the PI3 kinases that I showed you earlier. If you look at the wild type, the unmutated patients, the response rates are like half of this, like 30% and just a couple of percent. But nevertheless, the drug is approved for both populations, and the toxicities include fatigue, upper respiratory infections, musculoskeletal pain, nausea. And in the package insert, it says there may be an increase in secondary malignancies like hematologic malignancies. It's not clear that that's the case, and we require more patients with longer follow-up to be certain. So to summarize, in the front line, the approved regimens are rituximab or obinutuzumab, G, with either bendamustine, CHOP, or CVP. Rituximab monotherapy is occasionally used. I almost never did it. And I more frequently tried to use R squared, but that is an off-label indication. For the second line, bendamustine obinutuzumab based on the Catalan trial that I showed you, R squared based on the Augment study, and Y90 ibritumumab tioxetan. A drug which is a radioimmunotherapy in which you take a monoclonal antibody and you label it with a radioisotope and you give it intravenously to patients. It's been around for decades, but no one uses it because of a high risk of secondary malignancies. But it is on the market and it's very active, but it has its risks. And for third line, you have the Lissop sisters, 3 now, hopefully a 4th soon, and tazemetostat. Other therapies are also used. CAR T cell is not yet approved, is highly effective in follicular lymphoma with a response rate of like 95%, 40, 50% complete remissions, many of which are durable. And occasionally someone will still undergo a stem cell transplant, but those are not commonly performed in follicular lymphoma anymore. Now, the other indolent lymphomas are primarily marginal zone. I won't talk about Waldenstrom's because Dr. Treon gave a magnificent presentation in the spleen and extranodal called MALT lymphomas, mucosa-associated lymphoid tissue lymphoma. And these lymphomas shown on this figure can lymph nodes, spleen, liver, etc. What's fascinating about these lymphomas, the extranodal ones in particular, is that they are often associated with an infectious pathogen. For the gastric malt lymphomas, for example, Helicobacter pylori. For other types, Hep C, Borrelia, and I'll talk about the chlamydia in a second. And you treat the infection and the lymphoma frequently goes away and is cured. Amazing. Nobel Prize won a number of years ago. And these lymphomas are also occasionally associated with autoimmune diseases, Hashimoto's thyroiditis, and Sjogren's syndrome, the dry mouth, dry eyes, splenomegaly, etc. The malt lymphomas can occur in the head and neck, even in the brain. the eye, salivary glands, thyroid, lung, we call them baltomas in the lung or bronchial, the small intestine, the skin, and the most common of these is the stomach. This will be a piece of little known fact. Why did pirates have patches on their eyes? If you look on his shoulder, he's got a parrot. Parrots carry chlamydia psittaci. Chlamydia psittaci causes orbital adnexal lymphoma. That's the truth. It's because of the damn parrot. Okay. How do we treat these? Well, for the gastric molds, you treat the H. pylori, which can be seen under the microscope, little black dots there. Radiation we use not often, but it's very effective, but the side effects are also unpleasant. Rituximab is usually what we do if the H. pylori doesn't work. First rituximab, then rituximab and chemo, such as bendamustine. If that doesn't work, then we consider radiation. The non-gastric molds, again, you treat the infection, whether it's chlamydia, Borrelia, whatever, and the same sort of thing. If it's the skin, you might try topical steroids, maybe topical radiation, and again, rituximab with or without chemotherapy. For the spleen, about 30% are Hep C positive, treat it, and rituximab and chemo, PI3 kinase inhibitors, surgery. And for all the marginal zones, in fact, BTK inhibitors are also active, like ibrutinib. Here's the nodal. You treat it like a follicular lymphoma, bendamustine, rituximab, ibrutinib, acalabrutinib, or the PI3 kinase inhibitors. That takes care of the indolent. This is the whirlwind tour. And finally, Hodgkin lymphoma. There are two basic kinds. There is the classic Hodgkin lymphoma, which is about 85% or 90%. And this is a biopsy. You can see those big cells in the middle, like owl's eyes. These are the diagnostic Reed-Sternberg cells. And then there is the lymphocyte predominant, the nodular lymphocyte predominant, which we won't talk about because it's only 5 or 10% of Hodgkin's, and it behaves more like an indolent B-cell lymphoma. The treatment of Hodgkin's lymphoma has evolved over the years. About 20% of patients, 20, 30%, will present with early stage disease. And for these, a limited number of cycles of chemotherapy can be administered. This was a study of 3 cycles of ABVD alone or with radiation. And here you got over 90% survival long-term. So the radiation didn't add anything. For the advanced stage patients, we're still curing about 60, 80, even more percent of those. And one thing that's shown to be important is the interim PET scan. After 2 cycles, do a PET scan. If it's negative, you have the top 2 curves. If it's positive, you have the bottom 2 curves. And this shows that it's irrespective of the Hodgkin scoring system. The PET scan is very powerful. And if, as I'll show you, if you react to this, it works. So for the good patients, you want to reduce toxicity. For the high-risk patients, you want to improve their efficacy. And this study, called the Raffles study, has changed how we approach Hodgkin lymphoma advanced stage in the front line. Patients got 2 cycles of ABVD. If they were PET negative, they got 4 cycles of ABVD versus 4 of AVD, dropping the bleo. If they were progression-free, and on the right, overall survival, was no difference. You can safely drop the toxic bleomycin after 2 cycles. On the bottom, it shows that if you gave a more intensive therapy to patients who would have been expected to do poorly based on the interim scan, they did much better. And you can see that the difference in toxicity with ABVD versus AVD, there was more neutropenia, thrombocytopenia, infections, thromboembolism, respiratory adverse events when you had the ABVD versus dropping the bleo. Another new approach is based on the Echelon 1 trial, which was ABVD versus A for brentuximab vedotin or Adcetris VD. And it showed that there was a longer progression-free survival when you added the antibody drug conjugate, but with considerably different toxicity profile, more neutropenia, more febrile neutropenia, more peripheral neuropathy, for example. So initial treatment for limited disease is 3 to 4 cycles of ABVD or 2 cycles and involved nodal radiation. For non-bulky advanced disease, ABVD times 6, AVD and brentuximab times 6, or ABVD times 2, followed by AVD times 4. And for bulky disease, you treat them as if they had advanced disease. And to conclude, a couple of studies on relapse, 2 very effective classes of drugs, brentuximab in patients who failed stem cell transplant after chemotherapy, still had a 75% response rate, a third complete remissions. And then we have the checkpoint inhibitors such as nivolumab, in whether you were BV naive, you had auto transplant, whatever group, you had about a 70% response rate. And in randomized studies was actually more effective than BV. And there's another called pembrolizumab, and this also has about 60% response rates in advanced disease patients. So what we did, and this is my next to the last slide, is we actually said, if brentuximab is so effective and nivolumab is so effective, why don't we put them together and use them up front in older patients who couldn't tolerate chemotherapy? And we did this and presented this at ASCO. The response rate was 61% with 30% complete metabolic responses. The median duration of response was not reached, nor was the median overall survival. So we'll see where this goes. So to conclude, the lymphomas are a diverse group of malignancies with regard to their clinical presentation, treatment, and outcome. We have an increasing number of novel therapies, and a chemo-free future is out there in the near future for patients with lymphoma. Thank you. Most important thing I like to conclude is that you can prevent lymphoma. My favorite journal, Wine Spectator. Long-term wine drinking linked to low lymphoma death rates. That's why, as old as I am, I do not have lymphoma. Thank you.